So indications for lung transplant, for chronic obstructive pulmonary disease. Emphysema with or without alpha-1. I mean, it's that simple. If you're diagnosed with emphysema, that's an indication for lung transplant. Interstitial lung diseases, the ILDs, the fibrosises, the sarcoidosises, the LAM, lymphangiomyomatosis, the acidic granulomatous disease. Then we have our pulmonary vascular diseases, such as pulmonary hypertension. Now, you can have pulmonary hypertension without having COPD, but most times if you have an end-stage lung disease, you can develop some type of pulmonary hypertension. So it's one of those things that kind of go hand in hand. You come to see us and we're like, well, let's do an echocardiogram. Well, you have pulmonary hypertension, so that may change whether or not your candidacy is affected, because sometimes we have to kind of take that into consideration. And then Eisenmenger syndrome is a disease where the heart vessels are changed when you're born with it, and then we can go in and correct that surgically nowadays. Sometimes people with that need a lung transplant, sometimes they don't. So it really depends on the person. And then other, I say other, because there are lung diseases out there that we hear about or we see that we don't truly know how to classify. So we can't say that the person has fibrosis or they have COPD or they have something. We just don't know what it is. Even with lung biopsies, it's kind of confusing. They get these diseases called like NSIP or other things that are fibrotic, and we just don't know what to classify them as. We're getting better at it because we're seeing it. And then you have infectious lung diseases like bronchiectasis and cystic fibrosis. And then at some centers, and it's not done in the United States, there's a specific type of bronchoalveolar carcinoma, which is a lung cancer. But it's a specific type of lung cancer that when you resect it, unfortunately when you resect it, you have to take the entire lung. So then you have to do a transplant. Now, I will tell you, that's not done in the United States. I don't think it's been done in the United States for the last like 5 years. But it is done in Europe, so it's still in the literature. Contraindications for transplant. One of the big things, okay, is severe osteoporosis. So all of you probably know that when you have lung disease, you're put on prednisone most of the time. That, unfortunately, is bad for your bones. So that leads to weak bones. And if you have really, really weak bones, and we do a lung transplant on you, one of the mainstays of our treatment for anti-rejection is steroids, which is going to make your bones even weaker. There's nothing worse than having somebody who has bad spinal osteoporosis, who gets spinal fractures every time they cough, get put on more prednisone, and then break more bones when they've got a lung transplant, because then it hurts to breathe, and then they can't expand their lungs, and then it leads into all kinds of other problems. Other contraindications are severe musculoskeletal diseases. So these are things like multiple sclerosis or other muscle control neurologic diseases. If you can't take a big deep breath, a lung transplant's not going to work for you, okay? Because part of it is getting those new lungs expanded and getting the oxygen in and out. So that can be a severe contraindication. Malnutrition, I'm telling you, she runs around, Rachel, whew, I can't keep up with her, but she beats into you when she sees you how much nutrition plays a factor in lung transplant. And not even lung transplant, even after lung transplant or before lung transplant. You have to be healthy enough to be able to survive and recover from this big surgery. So nutrition is a key. Substance abuse. If you're using illicit drugs or you're using some type of drug that you shouldn't be, we really have to consider that. And if you're to the point where we don't think that you can stop it or you need to completely be off of it and you can't, that's a contraindication for lung transplant. Nicotine abuse. So if you're smoking, we require, and as most centers in the United States, 6 months of abstinence from nicotine. Now, notice I'm not saying cigarettes, okay? All nicotine products, patches, gums, the new e-cigarettes, cigarettes, cigars, anything that's got nicotine in it, we require 6 months abstinence. And that's, like I said, most of the centers around the country. Steroids, more than 20 milligrams daily. Again, that goes back to bad bones. If you've got steroids that you're using more than 20 milligrams a day, then you've got bad bones. Psychosocial problems. This is where our social worker kind of comes in. We also have a neuropsychologist that patients see. We want to know if you're really depressed Is it because of your lung disease, or is it because of something else that we need to fix before we send you in for a lung transplant? Okay. Infections. Now, infections are an interesting one because there are a lot of people that have infections these days that are called multi-drug resistant. Now, that doesn't mean that they can't be treated. That means that it makes it a lot harder to treat. Now, if you have a bad infection that's hard to treat, and then we do a lung transplant on you and give you medicines that weaken your immune system, that's going to make that infection much harder to treat. And we have to take that into consideration. We know from experience in the lung transplant community that giving someone new lungs, who you put the new lungs in, and that's great, you get rid of the infection. The problem is that your airways start here and go all the way up to your head. So anything that's in your sinuses or the back of your nose or the back of your throat can get into those new lungs. So if you have multi-drug resistant bugs here, it's going to end up in there, and that's going to cause a problem. So we have to take a look at that, and we have to consider all of that. Prior chest surgeries. Our surgeons look at every CT scan of everybody who gets evaluated. We set in a selection meeting and we talk about it. And they discuss, can we do this? And then if they say, we can't do this, then that's a contraindication. Some things that kind of make it more difficult is if you've had a big chest surgery for, say, tuberculosis in the past, or you've had a number of times when you've had chest tubes and they've had to go in and do a chemical procedure to kind of make that lung stay up. Those make lung transplant very, very difficult because what it does is it scars the lung to the wall, the chest wall. And when they have to go in there and try to cut that old lung out, it makes it very difficult. And we've had times when they've done that for 6, 8, 10, 12 hours, just cutting the old lungs out so they can put the new lungs in. And that's never a pleasant transplant, ever. But the good news is that the more transplants we do, the more skilled our surgeons are, the faster they get at doing that. And if we know that somebody's going to have a difficult case like that, we usually have 1 or 2 surgeons doing that at the same time. So you may have one surgeon on one side, another surgeon on another, and they're working in tandem to make this happen. So we prepare for that. Mechanical ventilation. So if you're on a breathing machine and you need a lung transplant, that can sometimes be a contraindication. It depends on how long you've been on the breathing machine, because the longer you're on a breathing machine, the weaker your diaphragm is. And if you're that weak that we don't think that you're going to be able to get diaphragmatic recovery, and you're not going to be able to get strong and get off that the ventilator after the new lungs go in, we have to really consider that. Such a scarce resource, is it really a viable transplant to do? So some centers will do it, and we've done it. We've transplanted people from the ventilator for one reason or another. You know, it's been a short time, or they've been actually doing physical therapy while they're on the ventilator because they were on the ventilator for high CO2 levels instead of respiratory failure. Their CO2 is just high, so they need the ventilator to get that CO2 off. But we'll take a look at it. So what's end stage mean? And this is just basic guidelines for what we consider end stage lung diseases, okay? So the big ones is people with COPD, they know their FEV1, okay? Is it less than 20% of predicted? Is their CO2 higher than 50? Is their O2 less than 50? And then have they developed pulmonary hypertension? That would be end-stage lung disease for someone with emphysema, okay? Cystic fibrosis, FEV1 less than 30%. Frequent hospitalizations, they're coughing up a lot of blood. That's part of that disease process that tends to make people be end-stage. And then weight loss for CF patients. Interstitial lung diseases that are not cystic fibrosis, if their total volume capacity is less than 60% of predicted, or they have a resting hypoxemia where their oxygen saturation is below 88%, that is kind of a end-stage portion. The problem with interstitial lung diseases is that this person can go from fine to not fine very, very quickly. COPD usually doesn't happen overnight. Pulmonary fibrosis, you can be sick and then, or be not sick and then be extremely sick. Pulmonary hypertension, it's based on pressures of the heart and cardiac output. And most of the time when people with PH come to us and we know that they're end stage, it's because they come in to meet us and they stand up to greet the doctor and they get lightheaded and fall down. That's when we know somebody with pulmonary hypertension is probably end stage. Before we even get an echocardiogram or anything on them, that's when we kind of know. So the natural history of COPD. Now, it's one of those things that, you know, the therapies that we have now are pretty good. People that get diagnosed with COPD, if they stop smoking or they remove themselves from the irritating factor, they can get better. Now, they can't get back to normal, but they can get better with drugs. It's sometimes difficult to predict the mortality risk of it because we have patients that we see for lung transplant, and we're like, you're too good for lung transplant. So we send them away. We say, come back and see us in 6 months, or if you get worse. They come back in 6 months, they're exactly the same. You're okay. Send them away 6 months later. And we do this for years. I mean, there have been people since I started working 10 years ago that we still see once a year or every 6 months that are still diagnosed 10, 15 years ago, and they're still doing okay with COPD. It just really depends on what's going on. The one thing with COPD is you have to think about it as, is my quality of life so bad that I feel like I'm willing to undergo major chest surgery to get 5 years after transplant? And that's what you got to think about. Okay? Because it's not a guarantee that you're going to get 1 year after transplant, but if you're going to get 5 years without a surgery, you should probably do that. Okay? So COPD is one of those tricky ones because I can tell you a number of patients come in and we're like, oh, you're too good, and 10 years later I'm still saying you're too good. You know, you look good, your quality of life is okay, just keep doing what you're doing, and you probably will never need a lung transplant. These are the ISHLT, which stands for the International Society of Heart and Lung Transplant. So this is what everybody in the country and everybody in the world basically follows. They progress despite therapy. So if they're on good therapy and if they don't get any worse, then they don't need a lung transplant. If their FEV is less than 25%, we consider them that's end stage and they probably need a lung transplant. Now, BODE score is just it's a tool that we use that kind of tells us how severe they feel their symptoms are. Now, I've had people that I see walk into the clinic on 8 liters of oxygen, and they're like, my BODE score is 2. I feel fine. But I've also seen people on 2 liters that have a BODE score of 8. So it's really subjective, and it's hard to use that one with most patients. It's basically what we kind of do to kind of fill in blanks. Now, listing is a whole other animal with COPD because we have patients that we list and they sit on our list because they're just not that sick. So their lung allocation score, which I'll talk about, is very low. And that's one of the problems. I mean, they may be on our list for 3 or 4 years without getting a transplant because their score is so low. So again, do they really need a transplant? Or do we just kind of watch them and keep going where we're going? It's always nice to have them on the list in case they do get sick, but at the same time, they may not necessarily need it. Alternatives for transplantation to COPD, lung volume reduction, okay? How many people have heard of this? Good. So I'm not going to talk about it, but I will tell you the gist of it. Basically, we go in, and in emphysematous lungs, we shave them down. That way, the current lung tissue has the ability to expand and utilize more of the lung space. Okay? Because in COPD, you develop these areas of dead space, and those dead space don't allow oxygen exchange. And if we get rid of those, you sometimes feel better. Now, it's not a fix, but it does help some people. The big thing with lung volume reduction is you cannot have pulmonary hypertension on echocardiogram. Because if you do, that changes the way that the blood shifts through the heart and lungs, and it can cause big problems. So that's a big, big thing. If you have pulmonary artery hypertension for your end-stage lung disease, you cannot have LVRS. And LVRS is only for COPD. It doesn't work in IPF, it doesn't work in SARCOID, it doesn't work in anything else, okay? And it can be used as a bridge to a transplant, but honestly, if we send you for LVRS and you get an LVRS and it works for you, you'll never come back for transplant because you'll be like, I feel great, you know? Most people, that's what happens.